I think that, as a medical oncologist, a lot of the times people are coming with a lot of anxiety, because often we see patients that present at a later stage of disease where the disease may not be curable. And I think one of the misconceptions is, what the expectation is. I think a lot of times people feel that systemic treatments or IV therapies may make them sick, all right? That there are toxicities to that or side effects, and that is true. But our goal really is to control the disease, shrink the disease, and do that in such a way that we really maintain quality of life and even improve quality of life. And from my perspective of treating many patients with liver, bile duct cancers, and other solid tumors, a lot of the time we do end up giving a therapy that can really improve their lives. And so I think that's one misconception. I think another misconception is that, we really will only give those therapies if we think, or I think that it's going to help. And so we balance everything in a patient's life, their medical problems, where they are with their cancer, and what is required to make those decisions.
Every individual's tumor biology is different, and that's the way to think about it, and that's how we try to think about it, utilizing whatever tools we have with the standard therapies as well as clinical trials to really try to improve the outcome of that particular patient and not a group as a whole. So I think I would say the biggest misconception is just, if you're stage 4, there are not many options. This is all, it's chemotherapy, and this is our poor survival. But that's really not the case, because it depends on so many of these molecular alterations and targets that we can do. And I think that's what I tell my patients anyway.
So pancreas cancer is a treatable disease, and that's important. And I think many people still have a lot of nihilism when it's associated with consideration of treatment for this disease. I think it's worth always getting an opinion, understanding what options are available, and then making an informed choice, as opposed to not considering that. So I think that's an important thing. And also in pancreas cancer, as part of taking care of a given person, we want to make sure that we're optimizing their symptom control, and access to supportive care and state-of-the-art recommendations in that regard absolutely help preserve well-being for as long as possible, and have been shown in many contexts to be integral to optimal outcomes in this disease.
Understandably and respectfully, I totally agree. Cancer is not a good thing to have, and if anything, we would like to get rid of it if we can. Thankfully, the studies that are ongoing in regard to the GI malignancies across the board, same like other malignancies, are definitely moving forward in the right direction. I would say definitely the first message is for our patients, definitely be optimistic, because after all, we're really working very hard to make sure that we pin down certain options of therapy for each one of you. Add to this, I would say to my colleagues is further analyses and further detailed understanding of the cancers are needed. The old days where just we look at the pathology and we say it's okay, it's adenocarcinoma or it's a primary liver cancer and that's it, these are gone. At the moment, the genetic analysis of the tumor is so critical, and we want to make sure that really we have a good understanding about all the fine-tuning things that really could be contributing to the tumor. For example, the impact testing at Memorial will be a very critical component of analysis of the patient's tumors, so we can understand better what does it mean, where it's come, where it's going to go accordingly.
Every breast cancer is the same. And every breast cancer should be treated the same.
I think the most common misperception from the public is that with metastatic breast cancer, people die quickly, because that really just is not the truth. People live for a long time with this disease with a really excellent quality of life.
I believe something that is pervasive is the idea that the more surgery we do, the higher success we have. And that's been shown over and over that our success rate with more limited surgical approaches is equivalent to a more extensive and radical surgery. So I think that's one misconception. Linked to that is the fact that people think if you do a mastectomy, you're eliminating the breast cancer risk. And that is not correct. The longer you follow up patients, then you start seeing patients who experience recurrences or new or other primaries in spite of having had mastectomies.
The biggest misconception for people who are not inside the field is that lung cancer is not treatable. And in today's age, we have immunotherapy, which have benefited significant numbers of people and even given some patients long-term outcomes that are starting to look potentially like cures, even with later stage disease. We identify new targets and new drugs for those targets on an annual basis. And patients are living longer than ever. The new data from the cancer statistics show that patients with lung cancer are living longer. And so I think that's now more in the public. The other piece of that is CT screening, where we know CT screening benefits patients, but insufficient numbers are getting screened so that they can be cured early of their disease.
I think the most common misconception for the treatment of non-small cell lung cancer is that everybody should receive a combination of chemo and immunotherapy up front. And I would emphasize that it's extremely important to first determine if those patients have driver mutations such as EGFR and ALK, and it's important to get those results timely. And if we find such a mutation, the patient should benefit from a targeted therapy first before using an immune checkpoint inhibitor. The second misconception is that patients who do have high expression of PD-L1 and who are not very eager to receive chemotherapy can be safely and efficiently treated with immune checkpoint inhibitors alone, if that is their preference.
It's not well known that actually all these armamentarium of targeted therapies is available, as well as immune checkpoint inhibitors. So another misconception is that immune checkpoint inhibitors may be used oftentimes without waiting for the genetic report on EGFR or ALK and ROS. And it is important to first wait for the genetic results before having an implementation of immune checkpoint inhibitors, because it has a negative effect if they're started on immune checkpoint inhibitors and then on TKI. But many, I think, practices, because it takes a while to get the results for genetic testing, or because it's easier to treat a patient perhaps with immune checkpoint inhibitors, and if they respond, they stay on that. They do carry these EGFR mutations up to 15-20% if they are Caucasians, 40% if they're Asians. So it's a significant number that will not benefit from targeted therapy. So I think that's another misconception.
What do community oncologists, what have they learned from this enormous and rapidly expanding amount of data, that because they deal with the lion's share of the patient population in the United States? And I must say, a lot of the data is confusing. So I think the biggest misconception is that pembrolizumab, that has been proven to be the winner of all of our currently available immune checkpoint inhibitors in patients with stage 4 non-small cell lung cancer, is the drug to use in every other setting. Patients with earlier stage disease or patients with small cell lung cancer. And that's clearly not the case. These other agents that fall just short in stage 4 non-small cell lung cancer are proven to be winners in other stages and other settings of lung cancer. So I think it's important to keep an open mind. As I said, the most important issue is that not all immune checkpoint inhibitors are the same. These are different molecules. We can't simply substitute one for the other. We need to work within the specific approval conditions for each individual agent.
Misconceptions in lung cancer field is that lung cancers behave the same. I've seen patients that had stage 4 lung cancer. spread to just about every organ of their body, have these miraculous responses due to targeted therapy. And I've seen patients have very small cancers that have ended up being disseminated and deadly. I think one of the most important thing I'd like patients to understand is that the biology has a lot more to do with how they're going to respond to their tumor than the stage. And I think we're starting to realize that more and more is the impact that a tumor's biology has on the outcome, as opposed to just where it's involved and what lymph nodes and what organs, etc.
So specifically with bone marrow transplantation, I think a lot of oncologists, especially who don't have a lot of exposure to it, think it's kind of a barbaric, kind of archaic procedure. Why are we doing this in the era of precision medicine? And I want to emphasize that in the right hands, it is a safe procedure in the right population, and it's still, there still are many diseases, including multiple myeloma, acute myeloid leukemia, where allogeneic transplant has convincing data that it's benefiting patients. And again, it's not meant for everyone, and there are complications, but we're dealing with really life-threatening diseases that these patients would otherwise die without the transplant. So we're dealing with high stakes, and there are some risks, but we do get very rewarding outcomes.
I think one of the things that's been the most important change in the last 5+ years, and maybe 10 at this point, is the importance that more actually is better. I think that it's still taken some time to recognize that the combination of 3 drugs is that much better than 2 drugs. So triplet therapy, and particularly triplet therapy, including the novel immunomodulatory in combination with a proteasome inhibitor, is really the triplet we're looking for from the get-go. And clearly now we're seeing that it's at a minimum, maybe triplet, maybe quads is the right way to go. So I think triplet is the message that still needs to get out. The second thing I would say is that autologous stem cell transplant still plays a big role. Now I'm biased, I'm a transplanter, but on the same token I would say is that until something is proven to be better than autologous stem cell transplant, we can't just do away with it. And there are a lot of trials that are out there that are showing that autologous stem cell transplant is complementary. It doesn't take the place, the novel therapy does not take the place of it. So I would encourage community oncologists or any myeloma physician that to send their patients to a tertiary center to be evaluated for stem cell transplant, because it still has a very important role in myeloma therapy.
Well, I think the common misperception about our specialty is that there is really nothing that we can do for AML in elderly patients. I have personally, treating AML in elderly patients, that's the bread and butter. The median age at diagnosis is 68. Many of my patients are in their 70s and 80s. With these new targeted agents, you can really do great things for patients that are elderly and even patients that present in extremis. I had a 78-year-old woman who presented with a white count of 130,000 on 6 liters of oxygen and had influenza A. I mean, this is this patient is a potential disaster, but she had a FLT3 ITD mutation, and we started her on Hydrea, then added a hypomethylating agent and sorafenib back in the day. And she had a beautiful response to that combination, got out of the hospital and achieved a CR on sorafenib, and was maintained on FLT3 inhibitors, first sorafenib, then gilteritinib, when it was approved for 2.5 years. And so the point is that with these elderly patients, I've been able to successfully deliver hypomethylating agents or hypomethylating agents plus venetoclax in people in their late 80s and early 90s if they have good enough performance status and you give appropriate supportive care and maintain a quality of life.
I think as kind of oncologists are often kind of optimistic to a fault. I think sometimes my colleagues in the hospital might view me and others that way. I think that's kind of our nature and why we went into oncology. I do think all of these research developments and the science and the newest therapies are I guess making that optimism more founded. I think we can truly be confident that we could treat especially our patients with CLL and indolent lymphomas well and have them enjoy high quality of life for pretty much normal lifespans. I suppose that is one thing that we can remind our colleagues that, yeah, patients with CLL nowadays should have pretty high quality of life. I guess we're not there yet with all of our patients. I think I wish we were. When I speak with such optimism, I am also reminded of patients where the treatments failed, and I hope we keep on pushing to make things better for those patients as well.
I think that's probably a misconception that patients need to be very fit in order to tolerate CAR-T, similar to an allogeneic stem cell transplant, but it's not the same. I think the toxicity is much more manageable with CAR-T than with an allogeneic stem cell transplant. And I think the second misconception is that we don't think about allogeneic stem cell transplant anymore, even though CAR-T failures can be cured by allogeneic stem cell transplant.
I do think we are at a time right now where we have a lot of development or availability of options, particularly with targeted therapies and immunotherapies, and it is sometimes hard to keep up with all of that. I do think that we are in a much better place in terms of treating hematologic malignancies. We have still a long way to go, but we are in a much better place than we used to be before.
I guess one misconception that I would think maybe some patients would think about going to an academic center to get their cancer care for lymphomas, maybe they would be concerned that they might not get that same type of personal relationship with their hematologist oncologist, maybe because they thought there was concern about time constraints or the potential to, because there'd be many different potential care providers, whether it's the doctor and nurses and learners. But I think one benefit that really is afforded to them coming to an academic center is that we fortunately have the time to really sit down with patients. We don't necessarily have all the pressures of a demanding clinical practice to really go over their diagnosis, talk to them about the potential prognosis, treatment options in the setting of indolent lymphoma if treatment is required, and take that time to explain everything to them. And I think that is really what really, and then have that expertise that is at an academic center that can be afforded there.
Inevitably, people always, when you're having conversation with, friends and family, holiday party, something like that, cookout, somebody will ask you, so what do you do? And I say, I'm an oncologist, and conversation stops. And they're like, oh. And so, and then people kind of like, they nod and they say, wow, that must be really hard. And I think there's that perception in oncology that, it is really hard, and it can be hard. But at the same time, I think I have the best job in the whole world, because I can always do something to help people. And I don't necessarily always cure people. We don't do that for a lot of people, especially some of these blood disorders, multiple myeloma, working on it, not there yet. But there's always something we can do to help people. And I think if you could just maybe change the way that people view oncology, whereas like it can be kind of a hard and sad field, certainly can, but there's a lot of hope, there's a lot of promise, and there's a lot of life and a lot of sustainability. And I like to think of my job as to give people life.
I think some of the misconceptions may be about the outcomes. And I think some people, some patients, may still think that prognosis is poor. I know it's all relative, but in terms of lots, all the different cancers out there, myeloma we're trying to start seeing as a chronic disease. So I think, people are starting to realize this, but prognosis is great. People can have a great quality of life. Longevity is improving. Quality of life, length of life.
The common misconception of follicular lymphoma is that we haven't made advances. When I started treating follicular lymphoma, and for the first 10 years of my career, every book and article and everything that was published would say the median survival was 7 or 8 years. And that really didn't change. And I don't think people are aware, by and large, about the revolutionary improvements in outcome that we've seen over the last 2 decades. And I'm not sure that people are aware, and we're just learning how to sequence all of the new therapies. And I think getting away from chemotherapy, getting toward targeted approaches, is something that has not penetrated as much into the general oncology community as it may have among lymphoma specialists.
Part of the privilege of treating multiple myeloma is that we have a lot to educate patients about when they're first diagnosed. And when people hear that they have a cancer, oftentimes they're not sure if it's a cancer of the bone or the bone marrow. And so we have to clarify exactly what the cell of origin is, how it causes bone lesions, and what the biology of the disease is. So I think the first misconception is sometimes people think that it's the cancer of the bone itself. The second misconception is that when patients hear they have cancer, they think that it is an immediately terminal process and they're going to die, and they're very concerned. And part of the privilege of treating multiple myeloma is that the disease tends to behave more like a chronic disease. Now, it is still considered a fatal disease, and the median survival is still only about 7 to 9 years for the average patients, but some high-risk patients will live less than that. So I think the misconception that people can't have a good quality of life and that they can't go back to the normal activities during their treatment is wrong, and then we try to explain them and sort of alleviate them of their fears that their life is completely going to change during their treatment, that they're going to get sick. Most patients will tolerate the standard triplet regimens fairly well. And so that's part of the privilege of treating this disease. We really get to know our patients well, work with them, alleviate their fears, and handle all of their issues as they proceed through their treatment.
The main misconception in multiple myeloma is the fact that it is not a curable disease. Textbooks always start with that, and I think so many things have changed in the last few years in myeloma that we are now at least making it a manageable disease. And certainly data just a couple of years ago showed that it was the cancer that had the greatest improvement in overall survival. So I think we now need to think about patients having a long survival and change our approach to managing side effects well, so that patients can stay on treatment, so that they can really benefit from the advances that have been made.
The misconception in ALL is, people think that treatment in ALL is the same, chemotherapy. I think that's not anymore the reality, especially now we are learning more and more about ALL, like Philadelphia positive or Philadelphia-like, and we can add TKI for these patients, like the dasatinib, all of these novel therapies, that we can target their drive in this case. I think it's not homogeneous. Every ALL is different, and the other misconception that is that a lot of people think that ALL only happen in pediatrics. So when adults doesn't happen, it's on the contrary. It does happen. It is rarer. It's a rare malignancy compared to the pediatric, and we are having better and better outcome because of these novel therapies. That I could say in a few years, if we continue improving, we'll probably have the same outcome similar to pediatric.
One of the major misconceptions, I think, is that you treat for only a limited number of cycles, then remove the treatment, watch and wait, then treat again. That's a historical paradigm that I think should change, in that we should now use induction to get patients to the deepest response, possibly do a stem cell transplant, but then maintain the responses for maybe 2 to 3 years to really maximize the benefit for patients up front, then leave them off treatment where their quality of life is excellent.
One of the misconceptions is that it's a benign disease. Some people don't think of MPN as a cancer, but we know it's a clonal disease. We know that there is mutation. Actually, it's a clonal group of disease. It's not one disease, but there is a mutation that happened in hematopoietic precursor cell, stem cell, that affect how we're making blood, and also have long-term effect on the way the bone marrow work. And in fact, they also, aside from the symptoms that they have, the complication of clots and things like that, there is also a risk of progression to acute myeloid leukemia. So we know that even though a lot of people think of it as a benign disease, it's actually a malignancy.
I can tell from our own, basically discussions that we have with non-medical oncology physicians that are in the field of oncology. It can be a surgeon, it can be a gastrointestinal doctor, it can be a hepatologist, and even supportive care doctors. We do have all these very valuable people in our team that without them we cannot do a good job with our treatments. However, I think sometimes there is this misconception that we are not considering their point of view in treating the patients. So I think medical oncologists usually are very comprehensive in how they look at patients and they evaluate them. Because it has everything to do with their underlying medical problems when it comes to chemotherapy. It has everything to do with their state of psychology, are they depressed or not? And so maybe there is some misconception that oncologists maybe are not so much taking into account the perspective of other specialties. But I want to emphasize that we are very much detail oriented, and we go through every single note and everything else, and anything that we do not understand, they know that we're going to call them and ask, or email or text or something like that. So that's something that I want to emphasize.
Being a GI medical oncologist is not always the easiest job. We would all acknowledge that very readily. Unfortunately, there still is a lot of nihilism surrounding some of the cancers we treat, whether it's pancreatic cancer or HCC, bile duct cancers, probably a little bit less so with something like colorectal cancer. We have to remember two things. First of all, we're here to take care of each other. And whether we can prolong someone's life or just be honest and have a conversation, those are important things as a physician to do. And then of course there's the whole academic side, which is we're here to make the world a better place. And our role in that, however minor or major it is, whether it's putting people on clinical trials or designing a trial or doing laboratory research, those are all very important things. And we have to be optimistic about this. We have to realize that one day things are going to be that much better than they are. We're making little increments, but we're waiting for some bigger discoveries. We've made some bigger discoveries. Deficient mismatch repair GI cancers that respond beautifully and often for a long period of time to immunotherapy. It's only a matter of time before we really start to make some bigger gains in some of these other cancers. So one thing I would love to get rid of is the culture of nihilism that surrounds a lot of these cancers, both in the oncology community as well as in the general medical community.
A common misconception, that we have patients that are on a clinical trial. We're trying to put them on a clinical trial, and so coming to our practice might be sort of a black hole. I appreciate that. It's great when patients can go on to a study, but the fact of the matter is that a lot of times a patient may come in and be a better candidate for standard of care and maybe be a better candidate for a trial in a later line of therapy, and we want them to come back for that. And so having a good rapport, I think, with the wider community and being able to say, this is a patient that I think doesn't need to go through the extra steps of maybe driving a little bit further, coming into the busy med center to get their therapy for something that is going to be pretty standard is fine with me. And don't be afraid to send somebody in for a study, because I promise you I'm not going to keep them just for the sake of having one more patient in my panel that you're not going to get.
I've seen patients come to me and they said, I got diagnosed in the ER and the physician said you have metastatic pancreatic cancer and you just need to go home and die. And that's fairly tragic, because we do have very active therapies, and though it may not be for everybody, there is a good percentage of patients who do get benefit from chemotherapy and from second line, and now we can sequence them, do germline, BRCA1, BRCA2, and kind of prognostically these patients do better, and we have other target agents for them. So that's the main challenge we face, is when patients hear pancreatic cancer, or if physicians hear pancreatic cancer, they just go, oh, we're just going to treat you with a couple of things or not treat you at all. So that's when we really think we want to enroll more patients on a clinical trial in earlier phase trials. So that means patients who are frontline, we want to put them in clinical trial second line, because that's the way we really change the delta in this disease.
As someone who has an interest in treating patients with pancreatic cancer, I think there's a lot of misconceptions from patients and from providers, especially non-oncology providers, that a diagnosis of metastatic pancreatic cancer is a totally hopeless cause, and there's really nothing to do for those patients. I've heard of patients who are told that they should immediately enroll in hospice and who otherwise have a good performance status, and I think that's a misconception that's worth kind of pushing back on. It's a terrible disease, but we have treatments that can prolong patients' lives and can improve their symptoms, and that's what we tell patients when they walk in the doors. If you have metastatic pancreatic cancer, it for all intents and purposes is incurable. However, I have drugs that I can offer you in the right patient that can help you live longer and can help a lot of the symptoms that you're having. And I think when patients hear that, a lot of times they are more encouraged than maybe their initial impression of what they read online or what they might hear from a physician or some other provider who maybe doesn't have as much experience with a patient who's actually gone through treatment for pancreatic cancer.
There's perhaps some misconception out there that at least in the community, I know that one of the things that we will sometimes see is that patients, and to a lesser extent, sometimes physicians, will feel that if they send their patient to a large academic center, that that they'll be a guinea pig, or that we're necessarily only interested in the patients that we can put on clinical trials, and that's the main that's the main reason why we would want to see those patients, and so I think that's just simply not true. Certainly we have an interest in clinical trials, but we sometimes see folks avoid MD Anderson, for example, for that reason, and we always hate to see that.
As a GI medical oncologist, I think there's a lot of confusion in regards to the GI portion. So do I do endoscopies or scopes or things like that? And we are kind of trained as hematology medical oncology, so we don't do GI interventions. Our intervention is systemic therapy, chemotherapy, immune therapy, and I would say that's probably one of the ones we run into in regards to misconception of the field that we do. And I think the other second level one would just be a more general clinical trial misconception idea. I think there's a lot of confusion about clinical trials and what those mean and how they work, and what are the criteria within a clinical trial, and what types of clinical trials there are. Not all clinical trials have a placebo. Not all clinical trials have the same level of evidence that kind of guides why we're doing the clinical trial, and so there's a lot of confusion, I think, around that.
We're learning a lot about pancreatic cancer, and pancreatic cancer has historically been considered a surgical disease, and what we're increasingly recognizing is that it is, in very few cases, a surgical disease, and I say that as a surgeon. It's not to say that surgery doesn't have a role in a significant number of patients. It's just to say that when you take the big N, all patients who present with pancreatic cancer, surgery is beneficial for, unfortunately, a very small minority, and that is the fundamental problem, because patients, because it has always been framed in that context, patients are always pushing for surgery, whether it is right or wrong. And quite frankly, many surgeons often push towards surgery, whether it is right or whether it is wrong. And I think patients are better treated when a real understanding of their disease and the potential benefits of the operation are put in context of the risks, and in the context of the fact that even at incredible centers, the operation is curative for an overwhelming minority.
So as a surgeon, I think that's one of the biggest issues.
I think that the big misconception in the space sometimes is, the role of clinical trials and, when is the optimal time to, participate. I think that it's always my feeling that, the best clinical trials are the ones that often can be used up front, and the frontline trials usually, they're very strong regimens that people have a lot of confidence in, and what we certainly hate to see is that everyone blows through like the standard regimens, and then they're like, okay, why don't we go look for a trial as a last resort. I think that really is depriving people of opportunities to get very novel combinations that we feel can really change people's outcomes. I think that some of the frontline data that like other people have been presenting really highlights that. Like those patients, many of those patients on those type of combinations have had very, very durable responses, and I think that it remains to be seen whether or not using those same drugs in a later line setting is something that's equally beneficial. I think cancer is always one of those fields in which you kind of use your best treatments up front, and we shouldn't think about it as we're saving up the big guns for the end. I think that there's a huge population of people that just don't make it to second line therapy, and then I think that what you choose up front is really, really important. And what you choose up front also sets you up for what you're strong enough to get later on.
The main misconception that we have with this treatment is that sometimes, or with these specifically the non-muscle invasive tumors and specifically the high-risk tumors, is that we do have what we know is a treatment that can cure patients. That is a radical cystectomy and a urinary diversion. So if we remove the patient's bladder and do a urinary diversion and the tumors are still non-muscle invasive, those patients have over 90% survival. So we have a very good treatment that can cure patients of their disease. Unfortunately, it is radical surgery, and it sometimes can be psychologically really cumbersome for a patient to have some type of diversion, but it is a cure. And the problem is that sometimes we wait too long. We want to keep patients' bladders as long as we can, which I absolutely agree with, but at some point we have to say, okay, we're going to try one or two treatments, and if these treatments don't work on these tumors, then we need to really push for that surgery that is curative, that we know can actually save a life. And that's one of the problems that we have, is we just may sometimes just continue trying, and then we get to the point where it's too late.